I hope you're well. Let's just wait for people to join.
Yes, let's wait a little bit more.
Yeah.
Hello, everyone.
Hi from yesterday. Welcome. Welcome, welcome. I can see some people already in. So I would like to welcome you all. And if you're watching this live, please take a moment to leave your name in the chat box, where you're from, what's your professional background. That would be super helpful to know who's watching and who we have with us.
Yeah, and we hope to be able to contribute to another session full of good sharing, good knowledge.
Yes. Yeah, we had an amazing guest yesterday, and we'll have another amazing one today. So we're both really excited. All right. Maybe we'll go ahead and start. So, hi everyone, welcome to session 2 of our 4-day challenge, where we'll be discussing all things lifestyle oncology. My name is Diana Ferreira. I'm a certified lifestyle medicine physician. I hold a master's and a PhD in palliative care, and I work for ESLO, the European School of Lifestyle Oncology, and we would like to officially welcome. As usual, I'm joined by Anabela Amarelo. Hi, Anabela.
Hi, how are you? So here we are for the second day. I'm an oncology nurse. As I told you yesterday, I specialize in rehabilitation nursing and later earned a master's degree in the same field. And my passion lies in integrating exercise and rehabilitation into oncology and palliative care also. And currently, I'm pursuing my PhD in nursing science. I collaborate with AIM and ESLO. So here I am with you, Diana.
Yeah, let's go ahead to speak about this second day. So I'm going to share my screen. Give me just a second. I think you're watching it now, if I'm not mistaken.
Yes, very good.
Okay, brilliant. So let's continue our journey in lifestyle medicine in oncology. And today's theme is rethinking evidence, navigating clinical trials in lifestyle and complex care. So we're going to be talking about evidence-based medicine. And the reason we included this presentation here is because we feel there's lots of misconceptions about evidence-based medicine, and we feel like people get there's lots of confusion in the research world as well, in terms of what's good science, what's not good science. And this is particularly important in the lifestyle oncology field. So let's discuss that. This is also like gives you a hint of the way we work in our school. So I guess it's super useful. So evidence-based medicine. We got this article from 1996, and this is just the origin, or this was one of the first authors to actually propose this concept of evidence-based medicine. And in this article in 1996, he says evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. So very explicit. And then he goes ahead and says the practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. So it's interesting because sometimes people are uniquely focused on research, but also this is about integrating clinical expertise with research. It's a bit broader than we usually what we're used to. And then he goes by saying, by individual clinical expertise, we mean the proficiency and judgment that individual clinicians acquire through clinical experience and clinical practice. Increased expertise is reflected in many ways, but especially in more effective and efficient diagnosis, and in the more thoughtful identification and compassionate use of individual patients' predicaments, rights, and preference in making clinical decisions about their care. So I would like to highlight that back in 1996, the concept of evidence-based medicine included the word compassion. So it's about what the patient prefers as well. It's, again, not only about research and the results of research studies. So to summarize, the evidence-based medicine is the integration of the best scientific evidence, clinical expertise, and patients' values. What we're used to seeing, though, is something like this. When you talk about evidence-based medicine, people focus a lot on scientific evidence, and usually scientific evidence coming from randomized controlled trials and meta-analysis. And sometimes they ignore everything else. But it's actually broader. And the same article, they say, without clinical expertise, practice risks becoming tyrannized by evidence. For even excellent external evidence may be inapplicable to or inappropriate for an individual patient. So clinical expertise, again, is important. But without current best evidence, practice risks becoming rapidly out of date to the detriment of patients. So we're really talking about integration here. And then in science, we're used to this pyramid, which reflects the levels of evidence. And we know usually that at the top of the pyramid, we have meta-analyses, we have randomized controlled trials, which are really considered the highest form of evidence. But it's a bit more complicated than that. So again, in the same article, they say evidence-based medicine is not restricted to randomized controlled trials and meta-analysis. It involves tracking down the best external evidence with which to answer our clinical questions. So we need to pay attention to the question we want to ask. And I think this is particularly important and especially true for lifestyle interventions, because many of those, while, for example, exercise may provide results in a relative short term, if we do other type of lifestyle interventions, they actually take longer, and a randomized controlled trial may not be applicable at all. And I'll give you the example of cigarette smoking. And in the 1940s, that's when we had the first studies linking cigarette smoking to increased cancer risk. But it wasn't until 1964 that Dr. Luther Perry of the US Public Health Service actually published the first report on cigarette smoking and health. And this was a review of more than 7,000 scientific studies. So we had lots of evidence by then. And even though even then they established that that cigarette smoking was a cause of lung cancer and larynx cancer in men, but only a probable cause of lung cancer in women, and the most important cause of chronic bronchitis. And nowadays we know that impacts and has influence in many other cancers. So it really takes time. And the reason is doing a randomized control trial with tobacco or with cigarette smoking was very difficult to do, because the length of the study would be it would probably be a long study, and it was not doable. So I want to bring this notion of the limitations of scientific evidence. And it's important to know limitations. It's important to know its strengths, so we can actually take a minute to analyze the evidence that comes to us. So one of the limitations is pharmaceutical industry participation. So we know that about 60% of clinical trials conducted in the EU are sponsored by the pharmaceutical industry. But if we look at the oncology field, we're talking about more than 70% of clinical trials. So we can see the potential bias here in results. And this is an interesting study published in JAMA, and it's titled Industry Involvement and Transparency in the Most Cited Clinical Trials from 2019 to 2022. And what they describe is that within industry-funded trials, about 89% reached conclusions favoring the sponsor. And again, among industry-funded trials, exclusive industry funding was associated with favorable conclusions for the sponsor. And these favorable conclusions for the sponsor were almost 3 times higher, more frequent than for studies only partially funded by industry. So it's quite an important difference. Now, I want to highlight that this does not mean that the data is fake. It's actually way more complex than that, but we need to recognize there are imperfections in the process, because we're all human, and naturally it's very frequent that there's bias in the process, and there could be bias in the study design. There could be bias in the selection of outcomes, in the statistical analysis we choose to make, and in the results interpretation. The other thing is data transparency. So when we publish a study, usually journals request us to have a data availability statement. And in this study that I mentioned from JAMA, most trials had one. So about 80% provided a data availability statement, and most indicated intention to share the data, but only 2.7% had actually data already readily available. Some data was under embargo, waiting for approval of the drugs, for example. Some data was accessible through contacting the authors, but it wasn't readily available. And the other issue is the quality of clinical trials, and this is slightly concerning as well. This was a study from 2021, and we could see, or it was estimated, that about 44% of published clinical trials had some errors. And this could be either statistical errors, incorrect calculations, duplicated numbers. And about 1/4 of clinical trials had serious errors that could compromise trust in results. So this is another level of complexity as well in the analysis of clinical trials. And then dose and duration of interventions. And we know that people have different needs. For example, you wouldn't give the same dose of insulin to all people with diabetes, but sometimes in some lifestyle and lifestyle related interventions, there is no personalization. And for example, studies with vitamin D, we know that within the same group, we usually put a broad range of baseline values, or people with different baseline values, and that could potentially influence how well they will respond to an intervention. So these may lead to fake dichotomies of, saying that one intervention is worth it and the other one is not, when it's in fact a bit more complex than that. And then we need to watch out for how easily studies can be reproduced as well. So this cancer biology project was an 8-year effort to replicate experiments from high-impact cancer biology papers published between 2010 and 2012. And they gathered 53 scientific articles, and from these they were able to replicate 50 procedures from 23 articles, so less than half were reproducible. And from those, they achieved similar results in about 5 articles. So again, it's a limitation. In the oncology field, this was a study watching for results if they were reproducible and transparent. And in about 296 studies, we had about 65% assessed. And only 3.1% of these fully described the methods used. So another concern. And then we have outliers and means, and we know that most people are within what we call the range of normal and are around the mean in terms of a certain measure. It could be anything, but some people will actually not obey to the mean and will be quite far away from the mean, and they will be considered outliers. So when we're addressing or working with individual patients, we actually need to account for that as well. And then we will have, working in lifestyle and in lifestyle and oncology, we will have these happening to us as well, or we will have comments like these. I don't believe that lifestyle can influence health and outcomes, but this is really belief versus science. So it's really not comparable, let's say that way. And I would like to also talk about the absence of favorable evidence. And there's different, usually when we look at guidelines, for example, we have grades of evidence. And I'll give you the example of the Society of Integrative Oncology and ASCO guidelines. We have different grades of evidence. We know that A and B usually is a recommendation for the modality. We'd see there's at least moderate certainty that the net benefit is small, but we're not entirely sure. So it's actually, it can be recommended to individual patients based on their preferences and professional judgments. And then we have D, H, and I. And I think they're quite different. So, for example, for D, we recommend against the service, and we recognize the modality has no benefit, but it doesn't inflict harm to the patient. While with the H grade of evidence, it's different. So we're talking here about the harms outweighing the benefits. So it's different. It's different having an intervention that doesn't work or having an intervention that can harm people. And then the I is insufficient evidence. It doesn't mean that the intervention is not effective. It just means that we need to investigate further. So for interventions that are not recommended, there are actually quite different grades of evidence. So this is from a recent opinion paper published in Nature Reviews in Cancer in 2024. And the authors go and say some integrative oncology therapies may be recommended despite the low quality of evidence if there is some evidence for efficacy and a high safety profile. And I give you an example. For example, Reiki is something that people asked about a lot. The evidence is not fantastic to support the use of Reiki, but if the person is driving some benefit and without any recognizable harms, it's an intervention that may be helpful for some people and that we should consider on an individual basis. So we really need to be aware of this. Absence of evidence is not evidence of absence. The fact that we don't have evidence to support an intervention, it doesn't mean that it doesn't work. So we really need to distinguish between these two. But at the same time, there's lots of benefits of scientific research because it is a rigorous process. We have solid methodologies, we can replicate studies, and many of the problems we have, they're not actually in the method itself, but in the processes, in our bias. So there's always space to optimize those. It also informs clinical practice. In practice, we know that results inform the design of new and relevant studies. It has a true impact in health policies, which will affect us all. So I guess my main message is that scientific evidence is not perfect. This doesn't mean we should ignore it. We just need to be criterious and have critical thinking when we're looking at studies. And I leave you with this quote from Carl Sagan. So science is not perfect. It's often misused. It's only a tool, but it's the best tool we have. Self-correcting, ever-changing, applicable to everything. With this tool, we vanquish the impossible. And that's about summary of this. So I'm going to stop sharing now. All right. I think I'll take a moment just to say hello to everyone who said good evening in the chat box. So we have a social worker from South Africa as well, a wellness coach from Australia. Yes, so lots of different backgrounds, which is really lovely to see. Different health professionals from different backgrounds all together. And so we will continue our conversation today with Dr. Nike Pichet, and I'm so sorry if I'm pronouncing it wrongly, but I'll introduce Nike. So with nearly 3 decades of dedicated experience as a research nurse, Nike has traversed the front lines of healthcare, demonstrating unwavering commitment and pioneering spirit. Her personal encounter with breast cancer sparked a transformative journey, leading her to create the Cannabis Nurse Navigator in 2016, and we'll talk about that. Niki addresses stigma and bias within the medical system as a psychiatric nurse, championing a more empathetic and informed approach to patient care. She's a research nurse where she conducts human studies on THC and CBD. Niki earned also her doctorate very recently in 2023. So I'll take this moment to welcome Niki.
Thank you so much. Thank you.
Thanks for coming on board. And Niki, I would love to start by asking you, to tell us a bit about your journey. What led you to this field of work, and especially working with cannabinoid therapeutics? And yeah, just to understand a little bit of your journey until now.
First, I just want to clarify, I've been a nurse for almost 3 decades, but I've only been in research since, through school and upon graduation. So although nurses do research, not at this level. So I just want to start by saying that. And I'd like to say that my second battle with breast cancer in 2013 is what really led me to looking at my nursing and myself in a very different light. And I was allergic to the antiemetics with the nausea that I was suffering from chemotherapy. My first battle with breast cancer, I had a total left mastectomy, and that was in 2011. So it wasn't until 2013 that I really felt the true effects of chemotherapy and radiation and the true pharmaceutical interventions. Although I was first put on tamoxifen in 2011 after my mastectomy, I could not handle it as a patient because it made me suicidal, which is one of the side effects of tamoxifen that we don't often talk about in the journey of healing or surviving cancer. I started a blog called Breast Cancer and Me because I wanted to touch people through the eyes of a nurse, now a patient going through this journey and trying to see what it was like from the other side of the nurse's station. And when I started to do that, I had many people that started to write back to me stating how I should try cannabis and the healing effects of cannabis. And at the time, I was a director of nursing operations, and it's still federally illegal here in the United States, and I was afraid to lose my nursing license. And I saw an image of my son and I was extremely emaciated. And I struggled throughout my life with some mental health issues, and I'm also a suicide survivor. And I looked at this image, and for the first time in my life, I wanted to live. And I said, well, if I don't survive, it doesn't matter if I've tried cannabis or not. I won't be a nurse because I won't be here. So I thought at this point I had nothing to lose, and I started to introduce cannabis into my regimen. And I did it through the legal chain in the United States. I did live in a medically legal state, so I did obtain my medical patient card because cannabis is a qualifying condition. And from there, I approached my treatment team at Dana-Farber Hospital in Boston, Massachusetts, and they said, we don't mind that you're using it, but we are not talking about it, and we are not going to help you use it. So I went on a deeper journey through my caregiver and people in the cannabis community and the cannabis nursing community that I didn't know existed, and found ways to use my cannabis for me effectively for what I was hoping to gain.
Thank you.
Thank you so much, Nikki, for sharing that with us. There were moments for you of great emptiness. I think you were with this wall, don't know what to do, and that led you to find a way to recover. And that is a journey that we are inspired by your story, and the fact that you could experience that in a so deep way led to your amazing program. So what can you share about that program, Nikki?
Through the journey with cannabis, I started to really understand more about what we're calling this integrative oncology. And it's looking at the mind, body, soul, and spirit. And cannabis introduced that into my life. And from there, I started to reach out into learning as much as I could personally, not professionally, but personally, about different alternative choices, such as acupuncture and equine therapy and cupping, float deprivation therapy, Reiki, music therapy, journaling, exercise. I also used cannabis and bodybuilding to get me through my second battle with breast cancer. And I often wondered why my years in psychiatry as a patient, why even my psychiatrist or care team for my mental health never introduced anything more than just pharmaceuticals to my care. So, as I started to work with a program called the Lotus Theory, I started to take that deeper. And that was developed through Heather Manis from the Cannabis Nurses Network. And I took it upon myself to branch it out further for me in hopes that it might help other people struggling in my interpretation of her theory. And I developed positively processing perception, which is a way that we can look at being the victim and turning it into becoming the victor and taking our life experiences and looking at them in a positive perception and looking at them in a way to be grateful. We all have life experiences, and everybody shares a different perception of life, even identical twins. You can have identical twins that have been born and raised in the same exact lifestyle and home. And if you separated them and asked them the same questions, showed them a picture, shared a piece of music with them, they would both have a totally different interpretation of their perception of what that meant. From there, I really started to work with the 420 support group in California in launching this program and helping others. And we would share a quote or an image or a piece of music and go around the group and ask what each perception was and if there was a trigger and what that trigger meant. And over time, just in that hour of a group, everybody started to understand that we all have similarities, yet we all have differences, and started to understand that sometimes we are responding to triggers that sometimes we're too sensitive, or sometimes we're not understanding, or sometimes we're interpreting the message very differently because of how maybe that had impacted our life, even all the way back to our childhood, subconsciously through thoughts, feelings, and emotions that we might have forgotten about. So that's what I did with my toxic behaviors and the way that I responded to things in my life. Don't get me wrong, I'm still triggered and I still have this initial toxic response at times. But learning to understand what I call the pause, and the acronym PLEASE helps to stop it for a period of time. And the PLEASE stands for pause and listen. Exhale, breathing is very important. And then accepting where we're at, silencing the thoughts, and empowering ourselves to stop that emotional reactivity and move forward in a positive way.
Thank you so much. And it's so interesting the fact that you're incorporating as well different modalities. And I was wondering, I was particularly curious about using music as a healing tool and what type of effects you usually see in people. And I'm particularly interested in arts in general as healing tools. So I'm actually interested in music as well. So could you share with us what type of changes you see in people once these modalities are incorporated?
I actually used the PLEASE acronym within the inpatient psychiatric units. I was a night supervisor during COVID in a psychiatric hospital, so we had very limited staffing at times, and I always wear a fanny pack and I had my little speaker with me all the time. And this hospital did not have security either. The staff and the nursing, especially myself as a supervisor, was part of security when there was a very volatile situation that was going to take place. And we started to use music to help patients, even those that were psychotic, to try to de-escalate them and help them get to a place that maybe might have been more normalized for them in the confinement of a locked unit. And it was amazing how we saw how the pause in which we, in my program, got patients to stop. And that pause was simply squeezing, which is a mudra, and starting that breath work. And to as they do the breath work and they inhale, they're already decreasing their pulse and they're decreasing their blood pressure. And then once they got to a safe space within themselves, and of course within the physical space, I would ask them what kind of music they liked. What was the genre? What was their favorite song? And I use an app called Spotify. And I would just type in what it is that they wanted to listen to. And our hallways were also locked. So if I knew that it was de-escalated to a point that I wasn't in an unsafe situation, I would take them with me into the hallway by ourselves, play their music, and let them do whatever they wanted in the hallway in a locked space, but yet they were alone and they were able to engage within their thoughts, whether they were real or not, and within the music that gave them comfort for whatever it is that brought to them this safety and security. Now, sometimes the music might not have been appropriate around other patients, and sometimes it would be something that was triggering to me, because that's the very interesting thing about music, is that what I find comforting, you might find distracting, or vice versa. And so that was where I used it on the inpatient, and I still do. On the weekends, I work in geriatric psych, and we often listen to music. And it's amazing on this dementia unit how so many of the elderly patients all of a sudden can start singing songs that they have started to remember, or get up and dance and have this brightness about them where you can tell, even though they're severely cognitively impaired, this is touching upon something in their life that brought them joy and was a place in their life where there was some happiness and some memories that they wanted to recall. The last piece that I do, I mean, I do a lot with music, but one of the last pieces to share is I journal a lot and I blog. And what I do is I often type in again to the app like sad, emotional, instrumental music. And if I'm having trouble writing with a writing prompt, I'll find I'll find a motivational quote, or a quote that is, say I'm feeling sad, and I'll just type in, what is a quote about feeling very sad? And then I'll pick one that resonates with the way I'm feeling at the time. And then I'll write that down and I'll play that instrumental music and really think about where that quote is taking me, and where is that in my life, and where is that perception of what I'm feeling right now, and maybe what it used to mean to me. So that's another way that I use music, and I can find it becoming very emotional at times. Sometimes I'll be writing with tears in my eyes because of the impact of the vibrations from the music. It just really helps me to like be unstuck, or from where I'm like blocked or a writer's blocked or I'm afraid to put it on paper. It just helps to really bring the emotions to the forefront.
Yeah, amazing. Yeah, and there's from you were speaking, and I was sort of reflecting on how these modalities also sort of, it seems that they rescue a human part of us, which can be gone in a situation of cancer, or even when we're admitted to hospital, which is a very sterile environment. And it sounds like you're almost, yeah, rescuing that part of us that makes us human despite all the challenging situation. So it's brilliant.
And Nikki, what appears to be the downward trajectory is sometimes the revealing best of us. Uh,
Yes.
that is always something that makes me emotional. But thinking about advice for healthcare professionals, what guidance would you offer to nurses and healthcare providers looking to this integrate holistic and alternative therapies into their practice? Can you manage to do that advice? I know you are a speaker in some forums, I suppose, in your blog also. How do you advise healthcare professionals?
I think it's very important to not forget the human side of care. I think when we have gone through our own healthcare struggles as well, it really helps to understand the impact that our caregivers and our nurses have to us. There's a great difference between empathy and sympathy. Empathy is when you've actually gone through something and you can really understand how that feels. And sympathy is more of you feel sorry for me. You haven't done it, but you feel sorry that I'm going through what I'm going through. And I think although it sounds like a cliche, if we can really learn to treat our patients the way that we want to be treated, if you can really take a moment and stop the um, like the struggles of healthcare, the short staffing, the policies, the limitations, the boxes that were put in because of insurance companies and all of that. And just take a step back for a moment. Again, pause. That pause is amazing for so many things. I often walk around like this with my hands in my pocket so nobody knows that I'm doing it. So that way I can kind of just breathe through the moment and give better care, because I learned not to take for granted my health. I always thought money was so important. We're kind of live in a world where money is power, but you start to learn that health is power. And if we can empower our patients to understand the same, and work with our patients to take a moment with them and see what they want for their care. I didn't want to use pharmaceuticals. I'm not on any pharmaceuticals. Now, I'm not saying that that's okay for everyone. I'm fortunate that I don't have metastatic breast cancer. And there are people that have to live on pharmaceuticals for the rest of their living life. But I think it's sitting with patients and giving them choices, and also these integrative choices. Whether you believe them or not, that's not the point. The point is that we're there ethically to give our patients what they need, and they don't know what they want if they don't know what's there. And I think it's unfortunate that we don't give them what I call this wellness toolbox that they can carry away with them, because you would not send a carpenter to build a house with just a hammer. That house would fall apart. So, how do we send our patients back into the community with this little gift bag that they pick up at the pharmacy? And then once that is empty, they're empty. So that's what I would say, that as a nurse, as a provider, to really step out of your own bias and understand why we chose to be in the profession in the first place.
Amazing. Thank you so much. I was interested to know if do you have any particular story with any particular patient that you would like to share in terms of how this type of approach actually made a difference?
I just always smile when I think of my work on the night shift in that inpatient psych hospital. There's two things that really helped. One of them is with the Please program. And somebody asked, what is the E in Please? The E is to empower, because every time you're able to pause and stop that emotional reactivity and that toxic behavior, it empowers you to try to do it again. And it gives you that positive perception about yourself. But back to the patient, is that in psych, in the hospital that I worked in, there was the locked unit and then the hallway. And in that hallway was what we called the blue room. And if patients got really out of control, we had to lock the door, or they might end up in restraints, unfortunately. And it was to the point where I even had staff stopping and putting a little like boom box or speaker in the blue room with them when we were allowed to, and listening to music. And as I was walking around the hospital doing my rounds, the patients would be like, "Hey, Nurse Neek." And then they would give me the squeeze. So it was really neat. Or if I would see somebody that I worked with struggling, I would go like this and they would go like this. And it was really, really powerful. So that's something that I really, when I'm having a tough time, I think about those days. And then as far as like organizational behavior, which I'm really intrigued by, the night shift, of course, and psych and COVID and all of that was happening, I started to implement music for the shifts too. So like even the nurses stations were starting to play music. And then where the time clock was in the morning, I would have music playing, and then when the staff came in, and I would have a motivational quote on the whiteboard by the time clock. And as the staff came in, it was really fun, because after a while, I literally had staff dancing in to like work to punch the time clock. And it was just a really, really nice time to see some of this negative turn into a positive. And even people that didn't like to work with each other or had, issues in the workplace, when you're dancing and laughing and listening to music, it's really hard, like, to stay angry. So that was definitely two of the things that really come to mind when you talk about that.
Super interesting. And
Yes.
I was going to ask regarding that, how important do you think is that we as health professionals kind of sort of work on ourselves and regulate ourselves to be able to work better with our patients?
Personally, I call it mirror therapy. And
Mm,
I think it's really important to sit in front of the mirror, look at
yeah.
yourself in the eyes, because the eyes are the windows to our soul.
Mm,
And really think about how you feel, what you do, why you do it, and where you want to be. I don't think
mhm,
we can lie to ourselves. I know that,
mhm.
again, I speak of psych because that's my background, but I know that when I can connect with one of my patients, even if they're psychotic and we can make eye contact, I know that I'm safe. 99% of the time, when I've been able to make eye contact with a patient, even if they're psychotic, they will not hit me or hurt me. Now, if I can't get that eye contact, I know I have to step away. I think the same thing holds true for ourselves. If you can't directly look at yourself and look in the mirror and appreciate and love and like what's coming back, how can you bring that to the workplace and how can you bring that to the patients, which means that there's work you have to do on yourself.
Amazing. Thank you.
Thank you. Nikki, and what advice would you give to those who are now facing the exact same thing that you faced years ago, that downward trajectory, to help them to discover the best with themselves? What would you say to them?
It's something that my daughter taught me, and that
Mm,
sometimes we just need to go to bed and go to sleep because tomorrow is another day. And sometimes we can just wake up in a different space with a different thought and positively process how we're going to move forward.
Amazing.
it's really
Thank
a
you.
strong message. Yeah.
Yes. And we would also like to ask, how do you see the future of integrative oncology? What changes would you expect to see in the near future? And how can we contribute as health professionals to those changes?
I've seen them in my own treatment. Like I said, 2011 and 2013 with both of my diagnoses. And this summer, I went through two major surgeries for breast reconstruction because my implants had failed. So I did the lumbar arterial flap transfer. While I was in the hospital, it was amazing. We did leech therapy, which is totally alternative, another alternative therapy. And there was also staff that came in at different times of the day just to lay hands on me if I chose that as something that I would like to do with music and no voice, just music and just their energy there. And I've also had Reiki in the hospital and nutrition choices that seem to be getting better. We forget to talk about the food that we put in our body, and the nutrition is so important, and the gut health that we're starting to learn so much about, and how that can influence how we feel emotionally, physically, and such as well. So I'm seeing it and I'm hoping that it continues to grow. Now, Dana-Farber Hospital, 2 years after I spoke of my use of cannabis, Dr. Raphael Mechoulam, who's the grandfather of cannabis medicine, was awarded the Lifetime Achievement Award by Harvard through Dana-Farber Hospital. And I knew they were studying cannabis. Like, there's no way Harvard wasn't studying cannabis. So, again, these steps are happening. It's unfortunate that it takes so long, but keep planting the seed and keep showing up and keep presenting the options, and it just kind of branches out. The Cannabis Nurses Network is where I kind of started my journey, and from there, they helped me get to my doctoral degree, like you, Anabela, with the European school that you're in. And again, it's just opening our eyes to this new, it's not new, that's the problem, this old medicine that's coming back around. And also to look into the elders. that brought this medicine to us so long ago. Like, we can't forget the traditions of this medicine, then where it came from, and giving them the grace that they deserve, and why we have this that's been around for so many thousands of years.
Yes, and it's a bit of going back to our roots as well, right? Just not because modern science is actually quite modern, quite recent. So there's something about ancient times and traditions that it's very wise and that absolutely we should respect and learn with. Yes.
Diana, we can check the comments.
Oh, yes, absolutely. Um,
You
yes,
have
most people
a
saying
crew.
hello. Yes.
Nikki has a crew here.
Yeah, Nikki's crew is here
Yeah.
saying hello. Yes,
Amazing.
and many people just sharing that it's being really useful and productive. So it's good news. No questions for now, but you're very welcome to put some questions in the chat box as well. So please feel free to do that if you feel inspired to. I think we have such a special guest, and we can tell Nikki that it's this was born from a love for people as well, right? It's sort of in your essence to provide care to people and do the best you can at all levels, not only at the physical level. So yes, it's a project about cannabis, but it's a project about much more than that.
Mhm.
It's like rescuing the essence of people and really taking them through a different path, which is so important when we're just so focused on cancer at some stage. So thank you so much. We're sort of reaching the end of our time together.
I just
So yeah,
I would
go
just like
ahead.
to say, I would just like to say thank you so much for having me. I also want to say thank you to Sophia Reno for introducing me to everyone. And we were together in a breast cancer research study years back that we were part of together. And I would just like to say thank you to her as well for connecting me to this amazing program. And if anybody wants any further information, they can reach out to me. And also my website is theperceptiondoc.com.
Yes, theperceptiondoc.com. Don't forget, just reach
Yes.
out to Nikki's and practice the squeeze.
Yes.
So we would really like to thank you, Nikki, for coming on board and for having this conversation with us. I think it's inspiring, it's very useful, and we would love to stay in touch and collaborate in the future. Annabella, I'm sure you want to say a few words as well.
Yes, your energy is not only inspiring, but also empowering others. So thank you so much, Nikki, for share.
Thank you.
Thank you.
Thank you.
And thank you everyone who was with us today. So tomorrow we're going to be discussing the lifestyle pillars and its influence on our cancer patients. So please stay tuned for tomorrow as well. We'll have another special guest, and we'll see all of you tomorrow. Bye bye.
Bye.
Bye. Thank you.
Bye.